Good afternoon, everybody, and welcome to the webinar. Today, we are in our Stay in Control series, which is empowering patients to take control of their heart failure. Today is the third session in the series, and the topic is living and thriving with heart failure today. This is not your parents' heart failure. Mended Hearts is really excited to be here with you all, and our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. You can reach us on any of the social media channels, as well as at our website at mendedhearts.org or at our new Heart line, which is 1-844-HEART-87. You can get support and education and resources by calling that phone number. Before we begin, I just want to give a couple of notes. All attendees are in listen-only mode. If you can't hear, hopefully you can see my slides. To check the audio button on your personal computer to assure the sound is on. Please type your questions into the Q&A box at any time during the presentation. The moderator will read your questions during the question and answer period. So you don't need to wait till the end. Type them in and we'll read them as they come in. Please note that the presenter is not able to answer specific questions about you as a patient or your loved one, as they are not your treating physician. And finally, the PDF version of the slides, as well as the recording of this presentation, will be available on the Mended Hearts website following the event. So now it brings me great pleasure to introduce to you our topic speaker today, Dr. Matthew Lander, who is attending heart failure cardiologist at the Allegheny Health Network Cardiovascular, from Drexel College, University College of Medicine. I am Andrea Baer, the Executive Director here at Mended Hearts, and I am excited to turn it over to you. And Dr. Lander, you should have control of my screen and
Okay, thank you so much for the introduction. So as Andrea said, I'm one of the heart failure faculty in the Division of Advanced Heart Failure at Allegheny Health Network in Pittsburgh, and we do in fact have an affiliation with Drexel University College of Medicine. So let me see if I can click in here. There we go. So I can't take credit for the title. This was actually what was suggested in terms of what we'd be talking about today. So living and thriving with heart failure, and this is not your parents, or for some parts of my talk, grandparents or great-grandparents' heart failure. Unfortunately, with a webinar, sometimes we lose the ability to go have some back and forth, but if I was in person, I'd ask the crowd if anyone knows what plant this is. And since I can't hear any answers, I'll just go ahead and tell you it's foxglove, and that's a plant that's the source of one of the medications that have been used in heart failure for many years. So this is a very brief outline, but basically we'll be talking about what heart failure is, what some of the history of heart failure is, and how we've treated it over the years. Touch on the complexity of heart failure, how we treat it, what devices we use, and maybe what we do at the end stages of heart failure. So for those of you in the audience, I would love to hear at the end of this. Hopefully we'll get through these slides quickly and have some back and forth. Some questions that I've been asked before, at least in clinic, why do I have to see so many specialists? I already have a cardiologist. Why do I need to see another cardiologist? Which often for me is the case. I'm a second, a third, maybe even a fourth cardiologist that's seen patients sometimes. I don't want to be a guinea pig. Why are you changing these meds so often? Why do I have to be on so many medications? Which is of course another question that we see a lot. Should I ask for a second opinion? I think that's a question that I've certainly been asked before. And then I think this isn't working out. My treatment, I don't seem to be getting better. Who should I turn to? So, what is heart failure? There's a lot of definitions over the years. I think that for the purposes of this talk, we'll say that it's a condition where the heart muscle isn't pumping enough to meet the body's needs. And what the heart is pumping out is obviously blood that has oxygen that supports the cells and activities that your body is performing. When your heart is too weak, the squeeze of the heart, you may hear this term ejection fraction, which we derive from a variety of imaging studies. You can have reduced ejection fraction. You can have normal ejection fraction and actually still have clinical heart failure. And when that fluid, which often it is the source of your problems, the fluid builds up and pressure increases, that can cause shortness of breath and inability to function. It's challenging to treat, and over time, if we don't treat it the right way, your heart can get weaker. So really kind of, all roads lead to Rome, if you will. And so if we think about just what the components of your heart are, and we think about what can go wrong with those components, pretty much anything that can go wrong can lead to a final pathway, if you will, of causing heart failure. So if you think of your heart as a house, the walls of the house, the plumbing of the house, the electricity, all of these things can, of course, can go wrong. And so when we have the valves can become leaky. The blood supply to the heart muscle, the coronary arteries, ischemic heart disease, heart attacks. These are all somewhat similar phrases for the same problem. Blood flow isn't getting to heart tissue. The heart tissue can become scarred or starved for oxygen over time and injured, and that can lead to heart failure. Similarly, we can have even this tissue around the heart, the pericardium, can have diseases that lead to heart failure. And so a variety of different problems, electrical issues, rhythm problems that can cause heart failure, cause issues. So what do patients experience? It's not all shortness of breath. And so sometimes people are just tired. Sometimes they gain weight, which is fluid weight. They get swelling in their legs. Sometimes it's more, subtle, maybe loss of appetite, maybe some nausea with meals. Maybe the heart rate's going fast, they feel palpitations. Maybe it's just lightheadedness, or sometimes another family member notices that they're confused. These are a classification, the New York Heart Association, or NYHA, classes of heart failure. And this is more in terms of you guys seeing how sometimes your doctors may refer to you. Either you can see your clinic notes and you see, this phrase NYHA. And so simply put, class 1, no symptoms. Class 4, symptoms at rest, horrendous limitation. Class 2 and 3, a little bit grayer. 2 is kind of slight limitation with, somewhat moderate or more activity. Class 3, of course, would be a little bit more limitation, maybe with just, with even just walking around your home or doing typical activities of daily living, like getting dressed. So this gets into a little bit of the history of heart failure. So if you've ever heard of the term dropsy, I would imagine this was well before even most people's parents, if they'd had heart failure. But dropsy is an old term really for swelling. And so this is an old picture representing really dropsy is immense swelling in the legs. Now, again, we were going to focus on fluid. Not all that builds up fluid is heart failure, but certainly for the purposes of this talk, we'll be focusing on that. How do you get rid of fluid? Well, this is fairly old, but leeches. I mean, leeches, of course, were felt to be medicinal in olden times, and so applying leeches to literally remove blood volume was a treatment for a variety of ailments, but certainly in heart failure would actually be something that could potentially, up to a point, maybe help. Believe it or not, these are tubes that were literally directly inserted into the lower legs when people got so swollen with fluid that it was just directly drained from the tissues. These were called Southey tubes, and actually were used even up into the early 1900s as a way to sometimes drain up to 5 or 6 liters of fluid a day. And then, Paul Dudley White is a very, famous cardiologist from the 20th century, early to mid 20th century, who was based out of Massachusetts General Hospital in Boston. Wrote one of the really original textbooks on heart failure and heart disease. And one of the treatments that he really promoted for heart failure was, in fact, a venesection, which actually was literally just drainage of blood, just bloodletting, to try to get fluid off. Now, we would like to not have to lose blood itself to be able to get the fluid off, and I think, have made some advancements in that regard. But certainly beyond that, he understood what the problem was, getting fluid off the body. So have we gotten any better than that? Well, I do hope so. But to give you an idea of the impact of heart disease, this is just one way. I don't want to spend too much time on this graph, but basically, as you can see, this is a chart that's showing you the mortality from coronary heart disease. So basically heart attacks, coronary blockages, things like that. Now, it's out of this country, but it shows to you, because the US data is quite similar over this time period, that, starting in the 60s, we had immensely high incidence of mortality that over, decades has gradually improved. So we've obviously made strides in patients that have coronary disease. This is a slide that is incredibly busy, but basically that's the point. I really want you to see and understand the immense complexity that some patients and many patients with heart failure have. So most patients, almost half of patients that have heart failure, have at least 5 other chronic cardiovascular or non-cardiovascular conditions. And these can contribute to heart failure. They can contribute to hospitalization, of course, and even progression of disease. And the problem is that we really have to understand that even non-cardiac processes can contribute to the worsening of heart failure. And of course, they all really need to be addressed. And so honestly, even as I would say a subspecialist, truly, a specialist that sees a well-defined population of patients, this is my own plug for the importance really of a primary care physician to really be the quarterback that is trying to manage multiple chronic issues and chronic conditions, of which heart failure can be certainly one piece of. This is, again, I am clearly not going to take you through this whole slide. We saw the effect in heart failure of ischemic heart disease, of coronary blockages. That comprises a large percentage of our heart failure population. But here you can see the immense number of problems and causes for what we refer to as a non-ischemic cause of cardiomyopathy, or another term for weak heart muscle or abnormal heart muscle. And so a number of problems that can cause truly heart failure. And so then how do we deal with this this process and this issue of heart failure? So the evolution of heart failure medications is one that I think is very interesting. If we go back to just as recently as the 80s, again, in the spirit of kind of, this is not your parents' heart failure, we can see that back in the 80s, we did not have many choices for medications, even as recently as just 30 to 40 years ago. We had digoxin, which I touched on earlier, from the foxglove plant, has been known of for actually since Roman times, but really has been used in heart failure really as one of the only medications for heart failure for about 200 years. And then finally, earlier in the 20th century, we had the introduction of diuretics, of medications that could make the kidney urinate off some of this fluid. So hugely important and influential. But even up until the 80s, we didn't have really what we now refer to as guideline-directed medical therapy. And it's called that because, as I'll show you, we have had clinical studies that have demonstrated profound improvements in outcomes. And I'll show you what outcomes do we really measure and care about. If we move on in this bar graph from the 80s up through the 90s, we see some different medications that have entered use. I will say not all of these are in use. This is what is developed over time. For example, fluoxetine is not used anymore. In fact, was developed, thought to be a medication that could improve cardiac squeeze, and then was found to have more mortality when it was tested in patients and abandoned. Over the years into the 90s and 2000s, we finally revealed the importance of medications such as beta blockers, ACE inhibitors like lisinopril, angiotensin receptor blockers, ARBs, mineralocorticoid receptor antagonists, also commonly referred to spironolactone being one example. Nasiritide, a medication that, again, was studied, a lot of excitement about, abandoned because outcomes were not good. And then more recently, we'll go over some of these other medications, sacubitril valsartan, also known by the trade name Entresto, and avabradine as other medications that have had outcome improvements in heart failure patients. So this is some of the things that we have in our toolkit. We know, however, that these medications, even as they've been developed, even as we've discovered them, they have to be utilized, they have to be used. And so sometimes there's a disconnect with what patients get and what they should get. So for example, I don't want to spend a lot of time on this, but this is a bar graph that shows in a study of 3,000 patients that were in a heart failure clinic, that really the usage of these medications was suboptimal. Even when they didn't necessarily have a contraindication to their use, we saw their use was really less than what it should have been. This next graph, in a somewhat complicated way, shows that not only that, but the doses that we are getting these medications to are suboptimal, because we know and have studied that the optimal doses for these medications are really either the target highest dose that the medication can be used at, or at least the highest that a patient can tolerate. And sadly, this study revealed the gaps in our own utilization of these medical therapies, and that only 1% of eligible patients were on target doses of beta blocker, ACE inhibitor, or ARB, or ARNI, which for our purposes really means sacubitril valsartan, also known as Entresto, or an MRA, as I mentioned, spironolactone. And so these medications are really underutilized, and there's a lot of issues that go into the importance of why that is. Again, not to spend too much time on this, but the pyramid itself, because this apparently is projecting a little bit hazy, is that there's a lot of medications that we have at our disposal now, especially more than we had in the 80s and 90s. But what are the outcomes that we're looking at? You can see at the peak of the pyramid, we're really looking at improvement in mortality, or mortality and hospitals. So, we know that a hospitalization is really this important stake in the ground in terms of what a patient is dealing with their heart failure, and that we want to avoid it. And then unfortunately, people that do become hospitalized have worse outcomes down the road. And mortality speaks for itself. We clearly want people to die less of their heart failure. Hospitalization alone is in the middle. And then certainly some of the other outcomes that we've looked at in clinical trials. So hemodynamic or functional physical function. Do patients feel better? Or when we test with maybe a heart cath, a pressure cath, do the numbers that we assess on that test look better when we use this medication versus when we don't? And then next to that is quality of life or symptoms. Can we at least make their patient's quality of life better? Can we improve their symptom burden? And there's some medications that do that. But really the pinnacle really that we're after is of course to improve a person's mortality. And again, demonstrating the difference between the 1980s, 1990s, and now, now we have this, again, a pyramid of approach and a wide variety of medications that we use, of other interventions that we do, such as cardiac rehab, that can have a real benefit for patients. But what I'll show to you here is that really it's based again on how symptomatic is a person, and what is their NYHA class. And so what I would propose is that by using this very stepwise fashion, are we kind of left to a bit of a trial and error approach to our treatment? Do we really want to wait and see when the progression of heart failure is a well-known process? Do we really want you to wait? Do we want to wait and let you get sicker? And so that's why interval checkups are so important and vital to make sure a person is responding to medications, but also maybe a frame shift of how we should approach therapy, and certainly at least medical therapy. Because we have now what we are going to refer to as the 4 pillars of medications for heart failure. And we really are now emphasizing quad therapy and upfront quad therapy. And so what is quad therapy? So 4 medications that I've already alluded to and touched on. ARNI, again, that would be sacubitril/valsartan, also known as Entresto. Beta blocker. MRA, so that's again spironolactones, also Clarinone. These are other examples of MRA. And then the newest entry really is the SGLT2 inhibitors. And so what that medication is actually a class of medications that were initially developed for diabetes. These are medications known as empagliflozin, as one example, or also known as a trade name Jardiance. And so this medication now has had immense promise in terms of its results that have been achieved in clinical trials and improving outcomes in heart failure patients. And so now, just this year, in 2021, the SGLT2 is entering our guidelines in terms of being an upfront medication that should be used in heart failure patients. And I want to be clear, these medications and a lot of what I've talked about here for medical therapy is mostly for heart failure patients with a reduced ejection fraction, where that squeeze of the heart muscle is actually reduced. So important that really we're getting these medications on board early, we're getting them on board quickly, and that we're getting them to doses that are meaningful. And then that we reassess how they're doing, as you can see on the arrow on the left-hand side. And once we do that, those are the pillars. That's the foundation of the therapy. Then really we look to some of these additional therapies that I'll talk to you about. Really stated another way, again, just to reiterate and emphasize, is that these are our own guidelines. This is a look at exactly the flow chart that is in the Journal of American College of Cardiology from 2021, just from this year. This is a diagram that has looked different in the past, but has now been adjusted to certainly, as I pointed out, include SGLT2 inhibitors, but also right at the beginning, we're focusing on using the beta blockers. We're focused on using and prefer the ARNI, the sacubitril/valsartan. And then we're using these other medications where the clinical situation dictates, of which there are several. We could go on and we could have an entire hour about just medical therapy, but I want to show you some other things that we can certainly use in heart failure. And so again, the exact algorithm that is promoted from this same publication in the Journal of American College of Cardiology, emphasizing that initially we do a baseline evaluation of the patient, including lab work, including beta natriuretic peptide, or BNP, which is an important prognostic lab in heart failure. EKGs, X-rays, echoes, and whatever other testing would be appropriate. Perhaps it is a left heart catheterization to check the coronaries. Perhaps it is a cardiac MRI. That we're looking at titration of medications and follow-up in clinic, that we're doing this in a relatively quick fashion, 1 to 2 weeks. I see patients in referral. Sometimes they are seen initially and then told, come back in 6 months. I'm here to say that's not the way initial and new heart failure should be treated. We really want to, as you can see on the left side, really do intensification of medications in the first 2 to 4 months. Then we want to have patients stay on these medications for a period of time, as long as they're not worsening clinically, and assess response and how we, in best ways we know how. What if they are not responding and patient is, unstable, getting worse? So who needs help? And we have really an acronym of I need help. And really what this is a way for really for other physicians, being a primary care physician, maybe it's a general cardiologist, to trigger them to refer their patients to heart failure when things are not going the way it should. I'm here to tell you, kind of direct to consumer, really direct to you. If you have this, then you should really be wondering, should I be seeing an advanced heart failure specialist? So the I is IV inotropes, medications that are given through an IV to help the heart pump more. Severe symptoms, and I'll abbreviate some of these just in description. End organ function. Your kidneys aren't working. Your liver's not working. Your ejection fraction is less than 35%. You're getting shocks from your implanted defibrillator. You have one or more hospitalizations for heart failure. You have swelling in the legs despite diuretics, water medicine being increased. You have low blood pressure or a high heart rate that's not responding to medication. And then prognostic medications, all those medications I just showed you, if you're needing to decrease those doses because your blood pressure is dropping, you're not tolerating those meds, that's unfortunately a poor prognostic sign. So if you have one or more of those, and if this didn't display the right way, I may run through this slide a little bit quicker. Then you see a heart failure specialist, if you especially have two or more of those problems from I need help. At least with this slide, what I was trying to display is that a care team is really the basic tenet of an advanced heart failure clinic. And so there are a lot of things that can be addressed for a heart failure patient. And so again, a little bit hard to see, my apologies, but basically we in our heart failure clinic, at least at Allegheny Health Network in Pittsburgh, have a multidisciplinary team of nurses, of pharmacists, of coordinators, of dietitians, a social worker. We have palliative care that sees patients directly in our clinic. We have psychiatry that can plug in and see patients in our clinic. We have active research trials going on, and we have many coordinators that help us with that. And so there's a real team focus in our clinic to help patients succeed, because really we know, and has been shown in trials, that outcomes are improved and patients do better when we have a team approach. So let's move beyond medications. What really drives symptoms? We have already talked about it. It's really fluid and fluid accumulation often. And so how do we deal with that? So one way, and I don't want to spend a lot of time here, because I think in this same webinar series, you've had talks on what I'm going to tell you about now, which is remote pulmonary artery pressure monitoring. The remote pressure monitor that is available right now is something by the name of a CardioMEMS. A CardioMEMS is a device that you can see here down at the bottom. Sorry, it's very small. It's a paperclip type device that is actually a pressure sensor that can be inserted into the heart and rests in the vessels that leave the heart and go to the lung, and can actually at home assess the pressures directly in your body and really in your heart. We know from hospitalizations, I've already told you this, but these should be very startling numbers, really. 37% mortality 1 year after someone is discharged from the hospital for a heart failure admission. Almost 80% mortality at 5 years after a heart failure discharge. And so what we see over time is patients have this labile peaks and valleys type curve where they come into the hospital, we rescue them, and they continue on and they get hospitalized again. We want to avoid that, but that's what's been demonstrated from heart failure patients. We know with the pressure sensor that if we keep you in the green, that if we notice these pressures start to rise, the fluid levels increase, that if we act on it here and the green turning into yellow, that we can avoid progression to signs and symptoms, and even weight gain And that's why I would say that, you know, all the measures that we have used as a heart failure community to try to pick up on hospitalizations or worsening are imperfect. Weights themselves are imperfect. Why are weights imperfect? Well, one explanation is always that patients with heart failure are sick and sometimes they have a poor appetite. If that muscle mass or even fatty tissue in the body is broken down and lost because a patient can't eat and can't keep their strength up, their weight may stay the same if that weight they lose is just being replaced by fluid and edema. They might not even know their weight is changing, that their fluid is increasing because their weight is not changing. So to check the actual pressures in the heart, we can avoid hospitalization. And this has been demonstrated through trials that have looked at the CardioMEMS system. So that's one unique way that we have. What's another way? If some of you out there have heart failure, you either have or your loved one has a defibrillator, a implantable cardioverter defibrillator indicated for patients with a lower ejection fraction or that have had funny rhythms, ventricular arrhythmias in the past. And so this is a device that senses and can shock a person out of an abnormal rhythm. And it's been shown to improve mortality, the pinnacle, again, of that pyramid we talked about earlier. Some patients can actually qualify for biventricular pacing. As you see in this picture, there is a lead from this generator that's placed under the skin that traverses and goes to the left side by being placed by the electrophysiologist in the coronary sinus, a vessel that travels behind the heart. And by doing that, we can pace both sides of the heart, and people have been shown, if they meet indications, to have improvements in ejection fraction and also in mortality again, and certainly possibly in symptoms. I'm going to show you here a device that relies on the principle of cardiac contractility modulation. So this is a newer device that is through is called the optimizer system. And it's very much looks like a pacemaker, and it acts like a pacemaker in terms of that there are leads that travel to the heart. The difference here is that in patients, as I've shown you here, ejection fraction of 25 to 45 with class 3 symptoms, so fairly symptomatic, that are not eligible for the biventricular pacemaker that I just showed you in the slide before, that they can be a candidate for this device. These leads travel to the heart. They actually give an electrical stimulation to the heart for several hours per day, not constantly. It's rechargeable by a charger that is placed on the skin over the device. It actually has been shown to improve negative remodeling of the heart, can improve the size and shape of the heart, and even the function of the heart. And this is FDA approved for heart failure patients that meet those criteria. Another device, almost a device that looks like a pacemaker, is actually has a lead that travels up to the neck, travels to the carotid artery. And years actually of research have shown that stimulating with electrical signals, the baroreceptors that live and reside in the carotid artery can actually have an impact on the heart. And that's because of those baroreceptors that are there. Can actually improve blood pressure, improve diuresis, and actually improve heart rate. And again, this is a device that has been shown to have positive outcomes in heart failure patients, and is also FDA approved for implantation for folks that meet these indications. Again, an ejection fraction less than 35, they can't get a biventricular pacemaker, and some of these other things that I've shown you here on this slide. Valvular heart disease, well, specifically leaking of the mitral valve can cause heart failure. Sometimes heart failure itself and enlargement of the heart can actually cause leaking of the valve. These patients can be very symptomatic and have a lot of heart failure. There is a device that is placed through a catheter called the Mitral Clip, which is put in through a catheter that goes and is brought up through the leg and crosses over to clip the mitral valve. And this has been shown to, in clinical trials, to improve mortality itself. Fewer people die when they have significant mitral regurgitation, mitral leaking with this device. They're hospitalized yet less they have an improved quality of life. Ongoing investigation, of which we're a part of here at Allegheny Health Network, actually is underway for the tricuspid valve, the valve on the right side of the heart. Interestingly enough, there is also, for those that may have had or have heard of a TAVR, there is also valves that go directly, an actual entire valve that is implanted through a catheter that is being studied in the mitral valve position. So more to come on this. This is an exciting area. So what if everything else is failing? Patients are sicker, they're not doing well. And so what is an LVAD? So I'm going to show you here, and I hope you can appreciate that while we have made strides in terms of certain areas of heart failure, that the mortality when people reach the end stage of heart failure, class 4, is staggering and really is right in step with some of the worst cancers that can be imagined. You know, you're talking about here on this slide, a 75% mortality at 1 year. So we talk about replacing the heart. The heart's met its end, and we have to give a better solution. Medications have not worked. Devices have not worked. Transplant is considered the gold standard, but the supply is limited. As you can see on the right side here, 3,000 or so transplants a year, about 25,000 that need it. So it's a supply and demand issue. So that's where historically we've turned to artificial organs. So when was the first VAD, ventricular assist device, implanted? Well, to give you some something for comparison, the first coronary artery bypass was in 1960. Furosemide, which some of you will recognize as a diuretic water medicine, was approved for medical use just in 1964. So it's interesting that actually the first clinically used VAD, implanted VAD, was actually before we even had Lasix, furosemide. This was a device put in at Texas Heart Institute. It was pneumatically driven and was connecting the left atrium, the top chamber of the heart, to the aorta, and sewn in place in an open heart surgery. Unfortunately, back then in 1963, this patient unfortunately passed away after just a few days. To compare where we are and I'll show you actually another example. So that's just one type of pump. This is a total artificial heart chamber that the entire heart is removed and a brand new mechanical heart is placed in its position. The first was actually as far back as the 60s by Dr. Cooley in Texas, and amazingly bridged this person to transplant after a few days. But these devices are challenging, even now are challenging to manage total artificial hearts. And at least back in the 60s, 70s, and 80s had an immensely high mortality. To give you an example of what's necessary, this was the setup that was needed to power the artificial heart back then. So really not something that you could certainly go home with. To contrast this to what we have now, those are pumps that are used if someone is at the worst end of heart failure and an extremis, and really what we call shock. Now we have catheter-based flow pumps. Believe it or not, a catheter placed in the leg or even in the chest into an artery, bringing that up to the heart, placing that pump in the heart, this catheter, and this catheter has a pump built inside the tip of it, which drives the blood across the aortic valve and supports the patient, hopefully while their shock situation improves. So obviously an immense difference from what you saw on the previous slides that we have available to us today. The evolution of the left ventricular assist device is really staggering. We look in the 90s and we saw and this doesn't do it justice because it's not, you don't have anything to scale, but this was a massive pump in the 90s and early 2000s that really actually was fully implanted, but needed to sit in the abdomen. Compare that now with pumps that actually are much smaller and can sit in the tip of the heart and really not take a lot of room up. And this again demonstrates how small these devices can be. Are there still problems? There sure are. I mean, unfortunately, this device, as you can see here, has a cord that winds its way through the skin, and exits the abdomen and connects to a controller and then to 2 batteries. And so obviously that's it still needs to be powered 24/7, and it has, like I said, its own set of issues. This is demonstrating survival and really demonstrates, I hope, the strides that have been made for heart pumps, for LVADs, left ventricular assist devices. As you can see, the Rematch study in the early 2000s looked at LVAD, that large LVAD I showed you, versus medical therapy, which we know isn't very helpful in end-stage heart failure. Sure enough, at 2 years, 8% were alive with just medical therapy. And then we had the LVAD, which compared to that did a bit better, 24% at 2 years. Contrast that to now, where we have at least one option for LVAD is the HeartMate 3, where in 2019 data, we show that almost 80% were alive at 2 years. This is really rivaling what heart transplant can provide even at 2 years. So impressive strides. These are some of the very public faces of LVAD. Dick Cheney received an LVAD and then a heart transplant. And then Rod Carew, Hall of Famer baseball player, also received an LVAD in 2015 and then a heart transplant. What's the future for LVAD? Well, we want to eliminate the driveline. We want to have this device powered through the skin. We want to reduce the possibility of stroke. We want to make them lighter. We want to make the batteries lighter. We want to make the pumps smarter. We want them to respond to what you're doing, and we want to have them be smaller so we can have minimally invasive surgery. And cardiac transplant, is again referred to as the gold standard. The first was in the 60s. But what followed was an amazing explosion of transplant tempered by horrendous outcomes. By 4 years later, after the initial transplant, only 23 patients alive, 85% mortality. So it was really almost abandoned by almost every center across the world. Only 4 places did them through the 70s. And really Stanford and some of the other places that did carry on and continue transplant and believed in it, really drove the field in terms of what was needed. What was needed was for the other end of the science to catch up, for immunosuppression to catch up, for medications to help patients thrive and not reject their organs, to watch out for rejection and to improve treatment of cancers and infections. I'm showing you this. This is some of the cutting edge things that we have in transplant. How do we transport hearts right now from the donor to the recipient? Believe it or not, it's mostly still in a cooler with ice. And so this is a device, the Transmedics device, that's under investigation, but that we hope will arrive and allow us to travel further with hearts, to support the organ while it's being transported, to monitor its function and perfuse it better. And so hopefully we will be able to utilize more organs this way by using this type of system, and can use those coolers for perhaps some other use. Transplant rejection is a huge problem. Its incidence has declined over time with better immunosuppression, but really very interesting developments in terms of looking and surveilling for rejection. Now a blood test that can actually show us the donor's DNA in the recipient. And we know there's only one place that DNA can come from. It's from an injured heart. And so if there's more of that DNA, we can surmise that there's rejection and treat accordingly. So a very interesting test that is being used now. Let's get a little futuristic. Over the years, I've had questions, why aren't we taking animal hearts and putting it in humans? And, understanding some of the ethical implications of that. There's a study just a few years ago that was published in Nature that showed that a pig heart that was removed, modified, and adjusted and put in a baboon, that these primates actually had fairly good outcomes. And so people in this field that are doing research in this field think we're maybe only 5 to 10 years away from trials being done in humans potentially. And then I get a lot of questions about stem cells and gene editing. And I just wanted to take a moment to show you, first of all, a staggering slide here with just a lot of different applications of stem cells. Why can't you, doc, just put stem cells in my heart and it rejuvenates? And I get this question a lot, and I think there's a lot of really interesting research in this field, a lot of promise. For those that have heard of something called CRISPR, there's a gene editing really system that has been founded and has been applied in a lot of research, again, applications. And can we just, edit out the bad part of the genes and make the organs work better? Amazing promise and possibilities, not quite prime time yet. And then modern day challenges. And I think this is for the field of heart failure in general, and I'll be closing up here soon. I think today we're more than ever, we're very tied into the inequities that we have in our own country and in the world. And I think this, unfortunately, medicine is not spared from this. Studies have shown that African Americans and Hispanics have a higher prevalence of heart failure than whites, and that they somehow receive, are less likely to receive appropriate medical therapy and ICDs. And so, studies have shown that there's bias even in the heart failure community and cardiology and medicine at large. And so, we clearly need structural solutions to identify the barriers. To continue to improve on the social determinants of health and try to reduce bias across all of medicine, not just heart failure. And then COVID. I know everyone's sick of it. No one wants to hear it, but I'm not going to say some of the first few bullets about wearing a mask and staying 6 feet apart as I say them out loud. I am saying them, but the point is that please get educated about the vaccine. I know I've had a lot of challenging conversations with patients of mine about getting vaccinated. Please refer to the facts about vaccination, and the CDC is a good resource for that. But also just don't ignore, I think some of us have become used to coronavirus now, and some people are less scared about going to the hospital. But in the last year, we saw a lot of people scared to go to the hospital, ignoring symptoms to the point where they were worse off. And so please don't be someone that does that. So let's refer back to your questions. I want to take your questions. So I'm going to go through this quickly. Why do I have so many specialists? Well, heart failure is complex, and we really can help, and we can be part of a team that helps you feel better. I don't want to be a guinea pig. Understandable. Everyone responds differently, though, and so we don't know how you'll respond to a medication until we try. And there's a lot of medications. Why do you have to take so many? I hope I showed you that upfront therapy can really be synergistic with multiple medications coming at the problem from different angles and helping. Should I ask for a second opinion? Always. This is your right. And if you have a physician or a healthcare provider that doesn't offer you that or is uncomfortable with that, then I would say that might be a red flag. And I think this management isn't working. Who should I tell? Well, certainly anyone that will listen, but certainly your heart failure specialist. And advocacy and timing. So really, I want you to trust yourself. When you leave that door from the clinic, I don't know what's going to happen. I don't have a crystal ball. I sure hope you feel better and you get better, but you may not. It may be a couple days later. It may be a couple weeks later. And I won't know if you keep it close to the vest until you come back. And so you need to trust your symptoms. And if in the interim you're feeling worse, you need to call. And unfortunately, in heart failure, there is no neon sign that blinks and says, now is the time. Now is the time to get more therapy. Now is the time to see another doctor. Now is the time to get a transplant or a heart pump. And so you have to trust yourself. It comes back to that. We have to work together, have really challenging and difficult conversations about where you are now, what your goals are and what you want to achieve and get out of life, really, and how we can get you to that point. Is it with a transplant? Maybe. Is it with just, different medication? Maybe that. So a shameless plug for our own group here in Pittsburgh. I think we have an excellent heart failure team, surgical team. We see a lot of different heart failure problems. If you are close to Pittsburgh and you want a second opinion, by all means, please reach out. So I went a little over on time. I apologize, but I'll take your questions. Thank you so much.
Thank you so much. No worries on time. It's great. We do have a couple of questions already ready, and then I just want to.
Are you muted?
Can you hear me?
Oh, I might have turned off my own. Hold on.
Can you hear me now?
There we go.
All right. So we do have a couple of questions, but I just want to remind everyone that you can type your questions in the Q&A box, and we will take them. But we have a couple of questions ourselves after listening to the presentation, which was great, by the way. My first question is, speaking of COVID, there are two questions that I wonder if you could answer. One is, are you seeing that heart failure after COVID, post-COVID, is a problem? And two, what has COVID done to the heart transplant supply? Does it seem to be complicating things?
So excellent questions. I think heart failure is a major problem after COVID for a couple different reasons. First of all, unfortunately, we have actually seen patients that have had COVID that have actually developed what we would refer to as a myocarditis, an inflammatory process that has actually extended and affected the heart. And so we have seen people develop heart failure from COVID-19. We have also seen people just have worsening of their own heart failure pre-existing conditions and symptoms with COVID-19 infection. And then we have seen what I referred to later in my talk, which was unfortunately for those patients that were understandably concerned about contact with the healthcare community, maybe presented late with a heart attack, maybe thought that chest pain was from just indigestion for several days, and it led to a worse outcome and more heart failure later on. As far as the question about transplant, actually, no. I would say that in general, it's been an individual question for centers in terms of we even slowed down our own transplant evaluations for a period of time and donor acceptance really early on. But now I think we're kind of past that. We have pretty aggressive testing in place in terms of transplant.
Great, great. And so going back to, we saw when you were talking about risk of heart failure, that psychiatric medications can cause cardiomyopathy. But we also know that untreated mental health is an issue as well with cardiovascular disease. So is one better than the other? What would somebody make of that when you're seeing that statistic?
Yeah, I think that certainly there's no free lunch and there's no one medication that's all benefit, no risk. Certainly it's a couple different things. I mean, if a medication, whether it be for a psychiatric condition or other condition that's important to treat, is causing a problem, then we have to work as a team. As I displayed, I think we have to work with other specialists to come up with a game plan that still treats the underlying, the other medical problem, the non-cardiac problem. But that's certainly that we can see if there's reversibility. Because what I didn't touch on this is, I know the progression of my talk seemed like everyone's going to get a transplant or VAD, and that's certainly not the case. We want people to thrive and be on medication and recover their heart function even, which these medications can do. And so we hope we can, kind of at the same time, treat the heart failure, but also so I don't think anyone should have to choose, because there's no one medication that for the most part, that is the only medication that can be used for the most part for most issues.
Right. Great. Well, thank you very much. We have questions in the Q&A box, so I'm going to turn it over to Jody, and she is going to read the questions for you.
Hello. The first question from Bonnie is, how do you make a decision to have a CardioMEMS implanted, class 1 or class 2?
Right. So, and I think that I actually saw a lower question about CardioMEMS too. So I think I can hit them both. Really specifically for CardioMEMS, it's indicated in class 3 heart failure. So you're talking about fairly notable symptoms that are fairly limiting. We should have some baseline medical therapies. I told you, really those foundational pillars of therapy should ideally be in place. But it is class 3 is what's approved by the FDA right now, and by guidelines. There is a trial of which we're involved right now, the GUIDE-HF trial, which we actually hope to be releasing results actually next month, where we're hoping that class 2 symptoms maybe will show a benefit. I don't know yet. I'm excited to see so we can get that approved. But that's kind of where we are. So there's no contraindication to a CardioMEMS. You can get a CardioMEMS if you're on medications. We really think you should be appropriate heart failure medications. And if you have a CRT or a biventricular pacer, that's also not a contraindication to a CardioMEMS.
Okay, great. You did, I think, hit both of those questions. So that is great. The next questions are about SGLT2 from Richard, and he wanted to know, does it replace Entresto, and is it indicated for patients that have been using the maximum dosage of Entresto?
So it almost would show that slide again, but honestly, no. And this is sometimes the understandable frustration of patients is, what do you mean I have to be? Why do you want to start another medication? But really, those 4 medications I showed, again, just to summarize, the SGLT2 inhibitors, with which there are several, and again, probably just to use a trade name, Jardiance is probably the best known. Again, to use a trade name, Entresto, aka Arni, aka sacubitril valsartan, is really 2. Beta blockers, which we, again, where I showed on my progression, is one of the older kids on the block, but really is really still the foundational medication of all of heart failure. And then finally, that 4th one is MRA, it's a spironolactone or eplerenone. All 4 of these should be used. All 4 of them should be trialed, and all 4 of them should be pushed to the maximum doses allowed. So if someone's on a high dose of Entresto, it doesn't matter. They should really be trialed on an SGLT2 inhibitor.
Okay. The next question from Cynthia is, how early can you refer a patient to cardiac rehab, and when would you say no to cardiac rehab?
So I guess in terms of early, I would say, there's different roads. Like, again, all roads lead to Rome. For me, Rome is heart failure, and so when we're talking about all these different entry points into heart failure, really what we're referring to is sometimes heart attacks. Sometimes you come in the hospital, you have a heart attack, and you're left with heart failure afterwards, or you just found out you have heart failure. The squeeze of your heart is low. So sometimes cardiac rehabs will be a little bit hesitant until about a month after maybe your index or first hospital stay. But honestly, it's never really too early. As long as you're somewhat functional and can get to cardiac rehab center and do it, I'm all for it. It improves, and it's been shown to improve mortality, and it's been shown to improve symptoms and outcomes. And so definitely a good thing to try to get enrolled into. Unfortunately, right now, for patients that have a preserved ejection fraction, insurance still will often not cover it, unfortunately.
Okay, and that seems to be all the questions in our question box. The last one, oh, hold on, one just popped up, I think. If I understand you, you're saying that SGLT2 is a replacement for Entresto. So I think just some clarity on that.
Oh, I'm sorry if I wasn't being clear. No, not at all. It's not a replacement for Entresto. It is not a replacement for Entresto. It should be used in conjunction with Entresto. If you have heart failure with reduced ejection fraction, that ejection fraction number is certainly less than, let's say, 35 to 40%, then you should really be on or trialed on all 4 of those, kind of medication categories. SGLT2 inhibitors are different than Entresto, and one does not replace the other.
Great, thank you. Well, thank you so very much. Before we end our hour, I just want to remind everyone that next Thursday, April 29th at 2 o'clock Eastern Time, we will be back with our final session of the series with tools and tips for caregivers. This webinar will feature a roundtable of heart failure caregivers discussing their experiences and sharing their tools and tips for supporting a patient with heart failure. And Dr. Adamson, who joined us last year in our first Control series, will be back to moderate that session. Dr. Lander, thank you so much for spending the hour with us. We learned a lot and we appreciate your time. For everyone watching, thank you and have a great week, and we'll see you next week. Bye-bye.
Thank you.